Good morning, folks. We're just going to give it a couple more minutes to allow people the opportunity to join. Thanks for being with us today. All right, good morning. We'll go ahead and get started today. Welcome to the September 4th, 2024 public workshop to consider amendments to Nevada Administrative Code, Chapter 439. My name is Melinda Southard, and I'm a Deputy Administrator with the Division of Healthcare Financing and Policy for Community and Provider Supports and Engagement, and will be leading today's public workshop. Before we get started, I'd like to go over some general housekeeping rules and expectations. As a reminder, today's meeting is being recorded. Please refrain from putting the meeting on hold, but please do mute yourself to avoid disruption. To participate in today's workshop or provide public comment by telephone, you may join the meeting by dialing 775-321-6111, and when prompted to provide the meeting ID, enter 281-680-077#. You may then press *5 to raise your hand during the public comment periods to provide your feedback and comments. Individuals making comments will be asked to begin first by stating their name and organization for the record, and if you could, please spell your last name. Public comment will be limited to 3 minutes. If you choose to follow along with the regulation overview, I have also posted a link in the chat, or we will be posting a link in the chat to the drafted regulations for your reference. And with that, we will go ahead and get started. So this is the public workshop to consider amendments to Nevada Administrative Code, Chapter 439. The purpose of this workshop is to solicit feedback from stakeholders prior to submitting the final draft of the proposed regulations. Please note there will be a public hearing in the near future related to the finalized regulations. Testimony and written materials submitted during this workshop today will be considered prior to finalizing the regulations. You may also present materials or testimony for consideration by the agency by emailing, and it's all one word, communityanddprovider@dhcfp, so dog, Harry, cat, Frank, Paul, .nv like Nevada.gov, which we will also post that in the chat. For all questions, feedback, additional public comments, or additional information regarding the draft regulations, please also reach out to us at that email address. Now we will move into our second agenda item with the presentation. So I'm just going to change that. Okay. So for this agenda item, the presentation and public comment on proposed amendment to Nevada Administrative Code, NAC Chapter 439, Health Information Maintenance, Transmittal, and Exchange Draft Regulation Review. I will briefly review the proposed regulations in whole, and then ask for public comments at each general section, and then at the completion of that review. As background, Assembly Bill 7, or AB 7, from the 2023 legislative session, amended the statutory language regarding NRS 439.589 in describing the adoption of regulations to prescribe standards relating to electronic health records, health-related information, and health information exchanges. The bill prescribes the Director of the Department of Health and Human Services, in consultation with healthcare providers, third parties, and other interested persons and entities, by regulation prescribe a framework for the electronic maintenance, transmittal, and exchange of electronic health records, prescriptions, health-related information, and electronic signatures and requirements for electronic equivalents of written entries or written approvals in accordance with federal law. The regulations must establish standards for networks and technologies to be used to maintain, transmit, and exchange health information, including without limitation standards that require the use of networks and technologies that allow patients to access electronic health records directly from the healthcare provider of the patient and forward such electronic health records electronically to other persons and entities, and the interoperability of such networks and technologies in accordance with the applicable standards for the interoperability. The director appointed and convened the Electronic Health Information Advisory Group, which first met on March 7th, 2024, for the specific purpose to advise the director in the adoption of regulations pursuant to NRS 439.589, effective July 1, 2024. The advisory group conducted 4 meetings to develop proposed regulatory language approved on June 17, 2024. Upon receipt of the advisory group approved draft regulations, the department included one addition of draft regulation language to clearly state no provider of healthcare is required to use a health information exchange. This upholds the recommendations of the advisory group in allowing for 2 options for provider compliance, while maintaining alignment with all requirements as set forth into the bill. Now we'll move into the draft regulations. Beginning here with the proposed revisions to include additional definition for relevant terms to the chapter, such as interoperability, provider of healthcare, electronic health record system, health information exchange, and down here we also have person defined. I wanted to quickly pause here to see if there were any questions or comments on these definitions as proposed here in these draft regulations. And please feel free to use the raise hand feature if you would like to provide public comment, or press *5 on your phone to raise your hand. Any public comment? No. Okay. All right, we will move on. So next, there are proposed revisions that require a health information exchange operating in the state must be a member of the Trusted Exchange Framework and Common Agreement, or also known as TEFCA. Additionally, this section outlines additional requirements for the health information exchange, and I'll go down to those here. So this section here is all for the health information exchange, different requirements for the health information exchange. So there were some additional items that were included from the advisory group, items H through M here. And wanted to pause quickly to ask if there are any questions or comments on this section. Okay, next, we have added standards surrounding required components and capabilities of an electronic health record system in alignment with federal best practices. So this section here, number 2, is outlining all of the requirements of an electronic health record system. And then thirdly here, starting item 3, the draft regulations include compliance deadlines from the various groups of providers of healthcare, which are also detailed in Assembly Bill 7 from the 2023 legislature in section 2.8. And those are outlined here in section 3. Lastly, in this section, we have items 4 and 5 listed here, outlining provided options for compliance with the requirements of Assembly Bill 7, and the clarification that no person or entity is required to use a health information exchange. And quickly here, I did want to pause and ask if there are any questions or comments on these revisions to this section. Maya, I see you have your hand raised. Please go ahead.
Thank you. Yes, this is Maya Holmes from the Culinary Health Fund. It's HOLMES. And I guess it's item 4, we're going to be submitting a public comment letter reiterating the concerns we voiced during the June Electronic Health Information Advisory Group meeting. But I'll summarize some of those comments now. We very closely followed AB 7 through the Patient Protection Commission and the legislative session, and as well as provided testimony. And we really just want to ensure that the proposed regulations do not exceed the department's scope of authority established by the statute. The intent of AB 7 was to provide patients direct access to their electronic data from their providers, not to permit compliance through connection to a health information exchange. The proposed regulations indicate that compliance for providers is based on either maintaining an electronic health risk record system that meets the specified interoperability standards or maintaining a connection with a health information exchange. This conflicts with the provisions of Section 108 in AB 7 and the legislative intent, which prescribed the ability for patients to directly access their records from their provider. I know the small business impact statement states that the advisory group did not come lightly to this decision to have an HIE as a solution to compliance with AB 7. But we disagree with the advisory group's conclusion here and really reiterate that a connection to a health information exchange should not be an alternative to having an interoperable electronic health system that patients can directly access. AB 7 includes waivers for providers who do not have the infrastructure to comply and funding to assist those who would like to participate. This entire bill was intended, I know I'm being a little repetitive here, but to support the direct patient access to their records from their provider, and the HIE inclusion is the opposite of that. And AB 7 has no provision stating that providers can use an HIE as an alternative to be compliant. So we would like these regulations to be revised or rejected as they have inserted the HIE into this law inappropriately. Thank you.
Thank you for your public comment. Appreciate that. We will take that into consideration. Do we have additional public comment? Jim Fleming, I see you have your hand raised. Please go ahead.
Hi there, Jim Fleming, Fleming, concerned citizen. I'd like to piggyback on the comments by Ms. Holmes, saying that I believe the proposed regulations also far exceed the intent of AB 7, especially in section 1, the words, the department shall contract with the Health Information Exchange to be a contracted statewide exchange if blah, 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 commercially reasonable terms by January 1st, 2026. And then the following requirement at the time of its application be incorporated as a Nevada nonprofit and have a wide maintain and operate a master index, have 5 years of experience, payers that comprise a diverse and substantial number, et cetera. To their credit, only Healthy Nevada will be able to satisfy those requirements by January 1st, 2026. And that's great for them. But these rules basically state that the state will contract with an HIE and only they will be able to fulfill those requirements, making it very likely that Healthy Nevada will enjoy a monopoly over that service. And they will also have the option of a mandamus lawsuit if they believe that the conditions that the terms they're offering the state are reasonable. The term reasonable is not defined. Furthermore, requirements lower down in the proposed regulations make it very difficult for a second HIE to contract with the state, again, incentivizing the creation of a monopoly HIE. Now, HIEs operate in many states. In only a few of them is there only one HIE. Some states, California and Texas, have over a dozen. There's nothing really wrong with competition, as we've seen, especially in the state of Idaho, where a single HIE was often associated with non-competitive, no-bid contracts and wasteful spending. I urge this committee to make sure that the regulations don't exceed AB 7 to the point of creating an unfunded mandate. This committee was tasked with some legislative authority, but was not tasked with fiscal authority, which I believe it is exercising by discretion, albeit in kind of a sneaky, non-obvious way. And I also urge the committee not to create any laws that are in violation of Federal Trade Commission's rules against competition. Thank you very much.
Great. Thank you, Jim, for your comment. We will take that into consideration. Do we have any additional public comment on this section? Michael Gagnon, I see your hand raised. Please go ahead.
Yeah, thank you, Melinda. I was a participant in that Electronic Health Information Advisor Group that helped draft the proposed regulation. And I believe that the connection to the HA is both a viable and a cost-effective alternative to implementing a certified EHR. If you read through all of the state statutes, HAs are not excluded. As a matter of fact, they're particularly called out. And they're defined as any person, in this case a system, that connects disparate systems. That makes effectively every TEFCA QHIN also an HIE. And that means it also says they have to manage opt-in consent. You will find that that's not something any national network does. And we're going to end up with a situation where data is going to not be able to be shared in any kind of network whatsoever, because consent won't be able to be managed by individual organizations who are participants in those, effectively HIEs. If you follow all the rules of both the statute and the proposed regulation, you'll find that having singular HIE, perhaps under public scrutiny, like a public oversight, would be the logical and appropriate choice for how to both manage consent and to be cost effective in doing so. The issues with a single EHR being the solution and the patient access and forwarding is that very few patients actually use patient portals, which is the only way to gain access to their records that way, and even fewer forward those records. It's convoluted and challenging process to do that, and often results in unsecure communications because they use unsecure email to send those. Yes, they can legally do that, but that's not a viable alternative we want to put out there for our citizens. The idea that everything would be done through patient-directed exchange is not viable alternative to having interoperability in the state. It simply is not. So patients could do that. They could access their records and they could forward them. But what happens in the case of emergency situation, and what happens in the case with the elderly and underserved, who are least likely to be able to access that information and make it actually happen? That creates patient safety issues that we simply can't allow. A connection to the HIE fixes all of the issues with AB7, and there are issues. It provides data exchange in all situations. It provides a patient portal for access to medical records, and it automatically forwards records, and it fully manages the connection to a national QHIN and the necessary consent requirements of AB7. It is specifically called out in the law that HIE is allowed, not required, but is allowed. And I say we should be viewing that as the solution for this. If the state agrees that public oversight is required, I think that's a viable option. But it effectively has to act as a single, almost utility to be most useful to the citizens of the state. Thank you.
Thank you, Michael, for your comments. We'll take that into consideration. Do we have any additional public comment on this section? Jerry Reeves, please go ahead.
Yes, I think we have the need for a public utility that has regulatory oversight that enables the ability for a competition and for the ability to ensure prices are appropriate, since there would be comparisons with other states that have health information exchanges, much like you can have multiple energy companies or one energy company that provides the services that are overseen by the state government, with the ability to compare rates in other states to assure appropriate pricing. And those regulatory authorities have not had conflict with the Federal Trade Commission rules. So I believe that the need for interoperability to make it so that patients can more easily ensure that there is better coordination of care by having adequate, timely access to information when they are seeking services at multiple sites of care is superior and is a better value for Nevadans than to continue to depend on patients carrying CDs from one place to another and carrying pieces of paper from one place to another when they are seeking care at multiple locations of service. It's just not feasible for many patients in Nevada who have chronic conditions and transportation and social determinants interferences with accomplishing the onerous task of carrying information from one place to another. Thank you.
Thank you, Jerry, for your comments. We'll take that into consideration. Do we have any additional public comment on this section? Okay, seeing none, we will go ahead and move on. So let's see, moving to moving to proposed NAC 439.584 and 439.588, they're very similar, to include maintenance of patient confidentiality standards consistent with the Health Insurance Portability and Accountability Act of 1996, otherwise known as HIPAA. So this is the .584 section, and scroll down, apologies for the scrolling. And then this is the 588 section, again, so including maintenance of patient confidentiality standards here. And I wanted to pause and ask if there are any questions or comments on this section. Okay, seeing none, we will move down. Okay, so moving lastly, in the proposed draft regulations, we see the provision of standards to request a waiver of the requirements. And this last section to note the inapplicability of certain provisions as defined and outlined in Assembly Bill 7. So there's the two sections here. So the first section defines the waiver requirements, and then the second section discusses the inapplicability as is defined in Assembly Bill 7 itself. So now I would like to open the floor for public comment related to the proposed amendments to NAC Chapter 439 as presented today. If you would like to give additional public comment and are joining us virtually, I ask that you please use the raise hand feature to take your place in the queue. And as a reminder for those of us joining by telephone, please press *5 to raise your hand and be placed in the queue. So with that, do we have any additional public comment on these proposed draft regulations? Okay, seeing none, If there are any further questions regarding, oh, I'm sorry, apologize. I see Jim. Please do go ahead.
Hi there, Jim Fleming, concerned citizen. I have one issue with the inapplicability of certain provisions. I see that the new regulations would not apply to a provider of health coverage for federal employees or provider of health coverage that is subject to the Employee Retirement Income Social Security Act of 1974. There are a lot of government health agency contractors such as Accenture that do those things for the VA. They make large contracts with CMS and with Social Security. So if there were, for example, a situation where a large contractor such as Accenture acquired Healthy Nevada, they would not be subject to the provisions of NRS 439 because they are also a provider of healthcare to the VA. It seems like an odd way that a large contractor could get out of oversight and accountability. I think the committee should think about removing those two parts of the inapplicability rules. Thanks.
Thank you, Jim, for your comments. And to clarify, these inapplicability requirements were taken directly out of the bill itself. And so this language is already included in Assembly Bill 7 as inapplicable to these entities. So just to clarify. Do we have any additional public comment? Okay, seeing none. If there are any further questions regarding the proposed amendments to Nevada Administrative Code Chapter 439, please feel free to contact us at the email that was previously posted in the chat, which is communityandprovider@dhcfp, which is Dog Harry Cat Frank Paul .nv, like Nevada, .gov. All right, so I'm going to close out that agenda item and move on to the next. Are there any public comments concerning any other issues we need to address today? Any public comment regarding any other issue? Okay, seeing none, we'll move on to adjournment, and that adjourns our meeting today. So thank you all so much for joining us and hope you have a great day. Thanks.